Welcome to All Access DNA, the podcast where we explore genes and DNA to understand how they impact our daily lives. Whether you're curious about general concepts or want to dive deeper into the science of genetics, you've come to the right place. I'm Kate Wilson. I'm a certified licensed genetic counselor who has worked for clinics and labs in a variety of specialty areas. And I like to talk to smart people who can explain science in a way that is easy to understand. Whether you're a science newbie or someone just looking to impress people at parties with fun DNA facts, we've got you covered. Let's get started. Hey, DNA. Kate Wilson here with another episode of All Access DNA. In today's episode, we are talking to Anna Hurst, she, her, about what a geneticist does and what happens in a genetics appointment. Dr. Hurst is an associate professor of medical genetics in the Department of Genetics at the University of Alabama at Birmingham and an adjunct faculty member at the HudsonAlpha Institute for Biotechnology. Thank you, Anna, for coming on the show today.
Thanks. Glad to be here.
So first off, I thought it would be good if you could give our listeners a sense of what a geneticist does.
Sure. So, as a geneticist, I like to say that I see people, mostly children, who have anything different about how they learn, grow, and develop, and try to see if those features might be due to one underlying genetic condition. So, something within their DNA that might be leading to their symptoms. Because if we can figure out exactly what's causing their health features, then maybe we can do a better job of treating and managing their condition.
So it sounds like you see a variety of folks because of different features or things that they're experiencing. So why would somebody might need to see a geneticist?
So there are countless reasons. And one of the things I really like about genetics is that it touches all aspects of healthcare. So when I kind of use those descriptions of like learning, growth, development, that could involve things like neurologic conditions. So things like seizures or even developmental delays. Maybe a child's not quite walking and talking on time. But it also could be health conditions related to, the heart, the eyes. Sometimes we see people who have birth differences and parts of their body might not be formed properly, or they might have health conditions where those features aren't maybe working properly. We also see people who have like a family history of a genetic condition, and they want to know, could they be at risk? Maybe they don't have symptoms yet, but they know that something runs in their family that could have a genetic basis, and they want to know what their risk is.
And so how would somebody find somebody like you, a geneticist? Like if they fit that profile, they have either their family history or something else going on that they want evaluated, or they're looking for answers.
Yeah, so one challenging thing I think is that there's definitely not enough geneticists. So if anybody out there is interested in careers, this is definitely a career that's in high demand. We need more geneticists, especially as genetic testing is increasing. So right now, probably the best way is by talking to your primary care doctors and asking who do they refer to for genetics in their area. Many geneticists are kind of located at academic medical institutions, so kind of the larger medical centers in different states and areas. And usually there's a referral process since geneticists are subspecialists. It helps to kind of have information from your primary care or whoever's been working up your primary symptoms. But there are also places where people can self-refer and they could maybe, reach out themselves and say, these are my symptoms. Would it be appropriate to meet with a geneticist? There are even some like telehealth groups that are starting to reach out to people who maybe live in areas where genetic services aren't as accessible.
So if they weren't necessarily near like a large academic center, they still may have access to a geneticist.
Absolutely.
Okay. And so one of the things you had mentioned is you're looking at different things to try to maybe find an underlying condition or a reason. So how would a geneticist diagnose a genetic condition?
So genetics appointments usually are pretty long and thorough. Since we are thinking about every aspect of the body, we ask a lot of questions. And so the first thing that we do is thinking about someone's personal health history. Sometimes that even goes back to their birth history and prenatal history. So we ask a lot of questions and think about their early childhood development, any major medical issues they've encountered throughout their life. And then we also draw like a large family tree, something's called a pedigree, where we look at other people in the family and what their health features might be, because sometimes there's clues of things that maybe aren't exactly similar, but could have some common ties to genetic conditions. And then once we get all of that information, the medical geneticist is really involved in doing things like a physical exam. So looking for subtle clues on the outside. We look at, kind of the typical things that you go to a doctor for, like listening to the heartbeat and, hearing somebody's lungs and bowel sounds. But then we're also doing more of a visual exam where we can look at things like facial features, birthmarks, even like creases of the hands, looking for tiny little subtle clues that sometimes could be indicative of a genetic condition.
So you mentioned about family history and then like early personal history. So, when you were born. What if like I'm coming to an appointment and I don't know some of that history? Are you still able to provide information to that patient?
Sure. So definitely it's not uncommon that people might not have full access to their history. And we kind of work with the information that we have. A lot of that is just kind of putting together what information and kind of clues are available to us and just trying to at least do right by that patient, saying, look, this is the best information that they have. We're going to try to come at this through the best way that we can.
And then you also mentioned the other pieces that sort of physical exam might be sort of similar to what some of us have already experienced with our regular doctor, and these subtle features or facial features. And so one of the phrases that I've heard used before is dysmorphology. And my understanding is that relates to things like these features. So can you explain a little bit more about what it is and how you would use it to make a diagnosis?
Yeah, sure. So dysmorphology is actually the thing that got me really interested in genetics as a career. I remember being a like gosh, probably middle school aged and learning about how to draw a self-portrait. And they were talking about like rules of facial proportions. And I remember thinking that like, not everybody's face follows those rules. Why is it that some people, maybe their eyes are a little bit closer spaced together, or they might have like a larger mouth or different ear formations? And it turns out that a lot of the genes that are involved in brain development are also involved in early face development. And so facial features can sometimes be a really great clue to neurodevelopmental conditions and other genetic syndromes. So we will often use those facial features as a first clue and a first sign that maybe there's something unique here about this person's development. And certain features follow patterns that are more characteristic of some syndrome compared to another. So an example that some people might be familiar with is Down syndrome. So individuals with Down syndrome have some shared facial features that maybe make them look similar to each other, but honestly, for the most part, people with Down syndrome look like their family. But some of the things that they might have in common might be something called epicanthus, or kind of like a little bit of fold of the inside of the corner of the eye of skin, up slanting palpebral fissures, which just means from like the inside to the outside corner of the eye, their eyes have kind of an upward slant. But actually, those are really common features that you can see in the population in a lot of people. But when a geneticist kind of sees those features along with maybe some other things like shape of the head might be subtly a little bit more rounded, and with the right medical history, maybe a child who also has hypotonia or low muscle tone, those features might start to make you think, maybe this child could have Down syndrome. And it's not always like we can't always make a diagnosis just based off facial features alone, but there are some conditions where certain things become much higher on our list of suspicion, or what we call like our differential diagnosis, based on those features.
So it's kind of like it's one of the puzzle pieces that goes into some of the other things that you're doing, like the family history, some of the other evaluations. But just because you have one of these subtle features doesn't necessarily mean you have a condition. And in full disclosure to folks listening, Anna and I did go to graduate school together. And when we learned about dysmorphology, I remember a few of us were concerned about having arched palates, the roof of our mouth, like if it was too high or too low and what that meant. So some of us may have these differences, and it's just differences. It doesn't necessarily mean we have a condition.
Yes, absolutely. So a lot of these features, sometimes we think of them as clues, but they're really typical and normal throughout the population. Most of the time, it's really just when there's a collection of lots of features together, or features that maybe you don't always see in that person's family. So especially when we're evaluating children, we're also looking at their parents, because a lot of times these features might be totally common for either the family or just the ancestry group that somebody is from. And so just having a unique feature by itself doesn't definitely doesn't diagnose a genetic condition. We also talk about how everybody has some distinct features, and just having a distinct feature in and of itself isn't a diagnosis. But in genetics, especially before DNA testing was so readily available, I think doctors just had to use whatever clues they had at their disposal. And so it was at least one way that we could kind of do a quick office evaluation that could make us more or less suspicious of certain things. And again, a lot of that relates back to the embryology of like how bodies are forming really early in development, and that some of those same genes involved in the face are also involved in brain development.
Well, and so I like that you mentioned how some of these things evolved, especially prior to having DNA testing so
Mhm.
readily available. So tell us a little bit more about this type of testing and how is that used in conjunction with these other steps that you've talked about in making a diagnosis?
So one of the things I love about genetic testing is there's not yet a like one test fits all test for everybody. There's lots of different types of genetic testing. And one of the things we get to do in clinic is when we meet people, try to figure out like what's the right test for the right person at that point in time. And so some tests are really kind of high level, broad tests, maybe just looking at a person's 46 chromosomes, or typically people have 46 chromosomes, but not everybody. And that's one of the things that we can be assessing for in clinic. But then we can also do genetic testing that gets down to a DNA nucleotide level, looking for single genetic changes. And for some conditions, there's just one gene that causes that condition. So an example is something like neurofibromatosis. If we see somebody in clinic who has all of the features of this condition that some people call NF1 for short, we know that's usually caused by the NF1 gene. And so if we see a pattern of birthmarks or neurofibromas under the skin and maybe a family history of other people with similar features, we might know that there's just one gene we need to look for. Now, over time, we're starting to realize that even things we thought only had one gene associated with them might have other genes that look similar when they're changed, leading to a genetic condition or not. So, an example with NF1, there's also a condition called spread 1 or Legia syndrome that can look kind of similar. So, we started to realize it might be more cost effective and even time sensitive to test for multiple genes at once. And within the last few years, there's been some really exciting expansions in genetic testing availability, where labs can test for multiple genes simultaneously. Some people call those panels, where you test for two or more genes, sometimes even up to several hundred genes. And then there's even newer technology called exome and even genome sequencing, where we can look at all material, or at least a large amount of it, simultaneously. So doctors don't have to sit around and try to pick which genes they want to test for at once. They can just send a bigger, broader test. Now, the challenge with that is the more you test, the more you might find, the harder the interpretation gets. Patient's insurance might not cover it, and so the cost can become an issue. So that's why we really have to do these thorough exams and say, okay, for this particular patient, what's the question that we need to answer, and what testing would be most appropriate to help that person in that situation.
So you would say that we're not to the point yet where somebody could come in, you would collect a blood sample and send it in, and then get an answer back within a week or two, like kind of like what you see on some TV shows.
So, yeah, in most situations, probably not. There are a few tests that can be done quickly, but it's usually in some very narrow situations. We are getting a little bit more access to things like rapid exome or genome sequencing, which can be done in a few days, usually a week or so. Those are usually reserved for situations where people are critically ill, hospitalized in an intensive care unit. And so those results are needed really rapidly in order to guide their medical care. But even those at most institutions need kind of a thorough review by multiple people who all get together and say this is an appropriate use of testing.
So it's utilized, but sometimes you have the physical exam to kind of help narrow it down, figure out what testing might be most appropriate. I guess why would somebody want to know if it's an underlying genetic condition or if it's a gene change? What helps that person to find this answer?
So that's one of the things I really like exploring with patients when we're having these conversations. Not everybody who may have a chance of having a genetic condition wants to have that information. And so one of the things, I don't know if you'll have other guests on talking about genetic counseling, but that's also a really fun area in medicine to explore, where you can have a lot of conversations with people about the utility of genetic testing and is it really right for them? What impact might it have for their healthcare? What impact might it have on their family? And so people have different reasons for pursuing or not pursuing genetic testing. One of the things we also talk about is the medical utility. Like, would it change somebody's healthcare plans? Would it change our ability to manage and treat them? And one of the things that we often are looking for is trying to figure out, if we knew what was causing this person's symptoms, would we have a different treatment? Would we have a different approach? In some of those cases, there are new medicines, new therapies, things where better understanding what causes a disease helps you better treat it. So in those cases, we often will encourage genetic testing as a way to really have true personalized medicine and make sure we're doing right by the patient. In other situations, it might not necessarily change our management or treatment, but it could just give people better information on prognostication, kind of thinking what typically might happen in the future. Although we say genetics is never a crystal ball. Like, we're not going to be able to look at your DNA and know exactly what your future is going to look like, but we could say typically of what's been reported in the past for people with this condition, maybe their condition is progressive, maybe it's static or stays the same, and that could be information that's helpful for a patient or family to know about what to expect. Maybe a good example to use here is something like hearing loss. There can be hundreds of different reasons for somebody to have hearing impairment. It could be things they're born with that are genetic, but it could also be infections and other situational chance things that could occur as well. But for certain types of hearing impairment, there are forms that maybe respond better to certain treatment options like cochlear implants, some that maybe don't respond as well. And so having that knowledge could be really helpful if you're early in the decision-making process about how to best manage a condition. But there are also some types of hearing loss that are associated with syndromes or other health problems that could show up in the future. So some of those that I think of, there's a condition called Usher syndrome, where people maybe initially have hearing loss, but then over time they can develop vision loss as well. And that could be really important to know if you're planning a child's education path. Like, if you know they have hearing loss and then you're teaching them a lot of sign language, if you knew that they were going to maybe lose their vision or have some vision impairment later in life, maybe you'd want to think about other educational goals and not relying just on sign language that's very visual based. Start to think about other tactile ways of communicating and preparing for that, so that person's education can set them up for the most successful, adult future.
So it sounds like, I think with genetics is sometimes it's part of what the journey the patient's going on to try to get some answers, but might just be the beginning or towards the beginning of it, because there's still a lot of things that once you find out what's going on that still need to be done or tried, or like you said, even education plans or treatment plans that need to happen.
Yeah, and that's a really great point too. Especially when we are diagnosing people with rare diseases and rare conditions. One of the things I've heard parents say is that they're really optimistic that having a diagnosis will then lead to a clear roadmap. And it's hard in a lot of rare diseases where we might find the answer in terms of, okay, here's the name of this condition, but it might be something so rare that medicine hasn't totally understood the entire way that genetic condition works and acts in the body. We might not have a clear treatment. And I've had some families express some discouragement because they said, okay, now I feel like I've got an answer, but I also have 10,000 more questions. And sometimes that can be really emotionally challenging to help them through that process, because sometimes getting that diagnosis is really just the first step, and you realize that there's a lot more that science still needs to learn and understand, especially in such an emerging field like genetics.
Well, and I think that's helpful too for folks that are maybe getting ready to see a geneticist, or maybe have gone to see one, is that it provides information, but it's not necessarily like you said, provides a clear map of where we need to go at this point. And so there's still some things to figure out.
Yeah. And like sometimes we at least hear people say, at least if you know what a diagnosis is, you know what it isn't. And so there actually have been times where people have been misdiagnosed. And so having a genetic answer at least allows them to get wrong diagnoses, out of their consideration or off their medical chart. We've had people recently who were able to stop taking certain medications that they were prescribed thinking they had one disease. And then when they found out the right answer, at least they were able to have a more tailored treatment plan and stop doing the things that we know won't work for them. So I think even, sometimes even if there's a negative result, that can help us rule out some conditions as well. Now, genetic testing is never perfect in that. So a negative test doesn't mean you don't have a genetic condition, but sometimes people can find some benefit and power in the ability to even get a negative test result. So it's not all discouraging.
Yeah. Well, and I remember when I used to see patients, it was sort of like, yes, we're starting off with, it could be these like 50 things going on, but some of the tests, even if we don't find out the 1 out of 50, we can cross off like maybe 10 of these things. And so it's a stepwise, and it can be frustrating and take time, but it is allowing us to get closer to an answer, or closer to trying to figure out what's going on.
Yeah. And being able to have those conversations with families, I think, is one of the rewarding parts of genetics, and being able to set expectations and make sure that people understand how the information may or may not be used is a really important part of the consent process.
Mm-hmm. Well, and that was actually one of my questions is, so what are some of the things that you like best or enjoy in terms of working in genetics, whether that's in the research or the clinical setting?
There's so much that I love. I think I feel really lucky. I think it's a really great field to work closely with people and thinking about individuals' values and their motivations. And I love that I get to know my patients really well. I think part of that is through the history gathering process. And anytime you're drawing out like a family tree, you just really get to know people and where they're from. So I love that part of genetics, that I still get to connect with people on a deep basis, but I'm also using cutting edge technology. And that just feels like a great intersection for me. I love that I'm always thinking about new things, new tools. Example of that, just this morning, I was rounding on the inpatient unit, and we are sending a rapid genome on a patient who's critically ill. We got to talk with the family, but then also the medical team about why we were recommending the genome, why it might be helpful. And that's things that I think even 5 years ago, I probably wouldn't have imagined that was like my routine Monday morning, was sending a genome. So I think the fact that in genetics, we're always learning new things, we're pushing this boundary of technology and what science can help us with, makes it such an exciting field. The fact that I don't totally know what my job is going to look like in 5 to 10 years is also really appealing, because I think I'm also constantly learning, and that really excites me as kind of a lifelong learner. Also, the fact that in genetics we're moving a lot more towards new therapies, and that's something that we have to be really cautious about, because I know in the rare disease space, there's a big push where we want new therapies sooner. We want those to be available to patients. But we also know that we have to be safe. We have to make sure that we're not causing any harm, and that we really have done good research and good scientific studies before we bring new therapies to use in a person where that could potentially have negative impact. So I think one of the best things about working in genetics is the fact that we do have a lot of new knowledge that can open the door to new treatments and therapies. The hardest thing is trying to pace ourselves, especially when you're talking with parents who want this information and these treatments and therapies yesterday. Like if you have a child with a genetic condition, thinking about waiting for something to go through the clinical trials process and to get FDA approved can be really discouraging. So I think that's one of the hardest things is knowing that like we're on the precipice of so many new cutting edge tools and treatments, but we might just have to be patient and wait a little bit before we really have these widely available because of all the due diligence that we need to do and the safety and the things that are crucially important. But it is tough trying to like manage expectations and talk to families about why it's important to be thoughtful, to go slow, and to approach therapies with a sense of caution.
Well, and I appreciate you mentioning that. Are there some other things that you've found challenging about working in the field of genetics?
I think, like a lot of areas of medicine, one challenging thing can be insurance and payment for genetic testing. There's some genetic tests that have been around for 15, 20 years that some insurances still deem experimental. So I'm thinking of things like microarrays, which, goodness, since like 2007 has been our first line
Yep.
recommended test for kids with developmental delays. And there's still some insurances that think that that is deemed experimental by their kind of policies. And so sometimes getting coverage for tests that you feel are completely appropriate and medically indicated can have a little bit of extra barrier. So there's a lot of our administrative time that can be spent on doing prior authorizations or writing letters of medical necessities. That's a team effort around the office, and we have an admin team who can help with that. But it is unfortunate sometimes that payment for genetic testing can sometimes be a little bit of a barrier.
Do you see that there's still a large amount of things deemed investigational or experimental, or do you think that there's some things that are now becoming more routine? Because I think with genetics, it's kind of been seen at the cutting edge, but as we move towards precision medicine and we see more physicians able to order some genetic tests that are probably more common than others, are you seeing at least some of these things have better coverage or at least being mentioned, I guess, by the insurance as something that the policy may allow?
So it definitely depends on policy and individual plans. So I would say if people are thinking about having genetic testing, definitely meet with a geneticist and genetic counselor, people who can really think about, is this the right test for you given all the aspects of your situation? And the genetic testing process is definitely improving compared to the past. And we are seeing more and more coverage for even more cutting edge tests like exome and genome sequencing. I think part of it is just justifying why it's medically indicated. So it definitely is a little bit harder if somebody wants to do like an elective test or they don't have medical health features. They just say, oh, I just want to do this for curiosity. Those usually are situations that wouldn't be medically covered. But there are some groups that are doing a lot of evidence-based medicine reviews and kind of professional societies that are coming together to review data and show situations at a large scale where these tests have been useful, and trying to make the argument across larger healthcare systems that genetic testing can actually sometimes save money in the long run. And times where it ends someone's diagnostic odyssey actually might be really cost effective because you're sending one test that, yes, it might be expensive compared to lots of little tests, but over the course, if you've saved someone from having to get extra MRIs and echocardiograms and lab work that are kind of done for screening purposes as part of a diagnostic odyssey, maybe you're cheaper and quicker in the long run to do genetic testing up front. And so we try to make those arguments, and I think it's being heard and it's improving, but it's something within the field that we try to be really thoughtful about
Mm-hmm.
and thinking about ways that we can reduce barriers and help increase the access for genetic
Mm-hmm.
testing to the people that would benefit from it.
Right. Well, and I think it's helpful. You mentioned, seeing a geneticist or a genetic counselor or working with a healthcare professional that can help navigate some of that or figure out kind of in some of those coverage situations for health
Yeah,
insurance.
and I will say I think that's one of the challenges because some of these rules and regulations change all the time and can vary based on people's policies. And that might be why your primary care provider or maybe another subspecialist, like your GI doctor or your neurologist, might be a little hesitant to order genetic testing. And I would encourage people, don't get frustrated with those doctors. Like it really is because it can be complicated. Genetics is its own subspecialty. And so I don't fault any other physician who maybe doesn't have the total level of comfort with being able to send these types of testing.
Hmm. Yeah, it's sort of like, you go to your primary care doc for, you have a broken foot or something. They're going to want you to go to the orthopedist because they're the ones that are going to be able to treat that specific injury or that specific thing that's going on. So in that way too, it helps to see somebody who can specialize in the field of genetics.
Absolutely.
So one of the things I do want to ask is kind of like a past future question. So one past, what led you to become a geneticist? Because I appreciate you breaking down some of this because it's a lot in the field. It's a lot of knowledge. It's a lot of school that you have had to go to, but you make it seem very accessible and you do a great job explaining it. But kind of why did you want to become a geneticist? And then what was some of your like training background?
Sure. So I've always loved science. I actually grew up on a farm in rural South Carolina, and I remember we had a yellow dog that had a litter of black and brown puppies, and I was fascinated by this. I was just thinking about like how do animal coat colors develop, and when I got into middle school, learning about genetics and drawing Punnett squares, I thought was the coolest thing ever. And so I had always liked the idea of genetics as a topic, but didn't really know how you could use that in terms of future jobs. So when I went to college, I worked in a fruit fly lab, which was interesting, but I also realized maybe the pace of that work didn't really resonate with me. And I missed working with people a lot. So in college, I heard about genetic counseling as a career. That's where I met Kate. Is I went to genetic counseling school for a master's degree, and I loved it. Like I loved being able to talk to people about genetic conditions, talk to them about their health history, about their family, about their values and motivations for thinking about genetic testing. But also with that, I realized I got really interested in the idea of making a diagnosis and medical management. And once you have a genetic condition diagnosed, how do you best take care of that person? How do you treat them? Also, during that time, I got really interested in dysmorphology and the physical exam. And so, some of the things that are a little different between genetic counseling and medical geneticists are the medical management and the physical exam and the kind of treatment and medication side of, of management. And so with that, I said, okay, well, I'll decide to go to med school. So I did medical school with the goal of then doing a genetics residency. In order to do genetics residency, there's lots of different paths. But for me, I actually did 3 years of pediatrics first, and then I did 2 years of genetics training. So I try not to add it all up sometimes, but if you look at 4 years of college plus 2 years of graduate school for the master's, which
Hmm.
you don't have to do, that was just my personal path, and then 4 years of medical school, 3 years of peds residency, 2 years of genetics residency. It's about 15 years, but honestly, like it doesn't feel like that when you're working, and
Hmm.
especially once you get into the clinical years of medical school, you're seeing patients every day, you're in the hospital, you're learning, but you're also directly connecting with families, and at that point, it really feels like you're part of that person's healthcare team. So it doesn't feel like you're really in school for that amount of time.
Hmm.
I remember being a resident in genetics saying, like, this is the best. I want to be a resident forever because I felt like I had the supervision of my attending physicians, but I also had some independence. But that's when my supervisor also said, that's how you know you're ready to graduate. It's because you're having too much fun in residency. You need to go get a real job at that point.
I appreciate you sharing that because I knew it was a few years, and then like you said, you kind of had that ramp to the master's degree in genetic counseling back on, and I think what's good to hear about it is that there's several different ways to get to being a geneticist, and it kind of just what works for the person who's looking to do that, and that you can come back and go to medical school even if you've stepped away post undergrad, that you can find your way back to other things, and that it takes time to kind of figure out, all right, here's exactly where I want to be.
Yeah, absolutely. That's one of the great things about genetics is there are so many different roles and ways in which you can use genetics to help people. So I think finding that way that's best for you, knowing your personality, your skill set, the things that really excite you, that there's a lot of opportunity there, but it can also be really overwhelming when you're at that time in your life where you're trying to make those decisions and knowing that you're never really closing any doors. Some pathways might require additional training, but I also say it's really great to do that training when you're totally confident that this is absolutely what you want to do, because sometimes the days can be long and hard. And when you have that feeling in the back of your mind saying, like, no, I know this is what I want to do, I'm doing this for a reason, it can really help motivate you through the tough days, because the end is usually worth it if it's something that you're passionate about. I also talk to a lot of people who are interested in kind of deciding between genetic counseling and medical geneticist roles, and that's something we talk a lot about is like finding your flutter, like finding that part of it that really resonates with you. And if you were just to completely strip the job away of any titles, what are the parts of the job that you feel most led to do? What are the interactions that you find the most fulfilling? And then thinking, okay, well, then what's the training that I need to be able to do those types of roles?
I love that for the finding the flutter, and I'm now going to be using that when I would do my work with students.
Yes. Because, like there's that stuff that, like, if you're sitting around at night and you're like, I don't know, scrolling your phone thinking, like, oh, I want to read more about that. Or like you just end up down the rabbit hole, like, that sounds really interesting. That sounds really exciting. Like, pay attention to that because usually that means that's something that sparks your curiosity.
I think that's definitely good advice, and I will say that I just remember being so impressed and being like, Anna really wants this because so close to graduation, being done with school. She's ready to go back into it.
And
So
yeah,
you,
there are
you
days I look back and say, like, why? That was a lot of school. It was a lot of years. But then, it's one of those things I'm glad I did it once.
mhm.
I wouldn't want to do it again, but doing it once was absolutely perfect. It
Yeah.
got me in a spot that I'm really happy with. And also I think it gives me a unique perspective of really being able to appreciate the knowledge and the expertise of the genetic counselors on our team, because
hmm
then we're able to like really speak each other's language to know what are the things that people can most bring to a situation and make sure that everybody's really working at the top of their abilities, because that keeps all of us more fulfilled with the things that we're doing on a day-to-day basis. So
hmm
hopefully I have a greater appreciation for what the GCs are able to bring to the encounters.
I'm sure you do. So that kind of tells us like past how you got to where you are today. But then I want to look towards the future, because we talked about how genetics can be kind of cutting edge and you like working with some of the new technology. What do you think is going to happen down the road 5, 10 years from now in terms of clinical or medical genetics, and how geneticists are working with patients?
Yeah. I have a lot of hopes. I think there are some things that I'm really excited about that I don't totally know what it's going to look like. My biggest hope is that genetics is going to be more accessible, that hopefully we're going to have more opportunities for early testing. So at the beginning of somebody's diagnostic journey, not necessarily at the end once they've seen like 8 other subspecialists and then somebody say, maybe this is genetic. But I think getting testing earlier and having more thorough tests like exome and genome be more of a first line approach. There are some studies that are thinking about using genetic testing, early in babies in the NICU. We've been involved in some of those research studies where I work. There are also some studies that are even looking at genomes and exomes as part of newborn screening. And so I think these are really great opportunities for the field, but I think it's also important for us to think about the ethical side of this genetic testing early for people. Um, so I like the fact that we as a field are moving forward, but also thinking about the potential impact that these decisions can have on patients, but also on a larger population as well. So, I think that accessibility is a big hope. The other hope that I have is with treatments. I really think that we're going to have more customized, personalized therapeutics, um, more genetic conditions for which there are targeted therapies, and only when you know what's driving a condition can you figure out the right treatment for it. So I think we're just at the first step. Like, first you have to name it and you have to know, okay, this is what's causing the disease. Then you have to better understand how and why, but that's going to get you closer to a treatment. So there's a lot of talk about a lot of different types of things like gene therapies and things that I think we're really close to having more widely available. And I'm excited to see in the next 5 to 10 years what that really is going to look like for our routine patients kind of coming through your typical genetics clinic on a regular day.
Mm-hmm. And so having some of those more treatment opportunities, which is definitely exciting because I think there's more options today than there were even 15 to 20 years ago when we were looking into these types of things. So it's exciting to see, I think we all, those of us that work in genetics, want more options. It's exciting though to see that we have some where we used to not have any.
Yeah, absolutely. Like, one of the examples that I think of are some new therapies for forms of overgrowth. And I saw a patient recently that I had followed him since he was, maybe 3 or 4 years old. And he had some overgrowth of the soft tissues and the bones in one of his hands and arms. He's now a teenager, but there's some new therapies that have come along that can help with that. And we talked about the pros and the cons of these, but he's really interested in exploring some of these options because he likes to play sports. And so he thinks that maybe having a little bit less overgrowth could help with him being able to live the quality of life that he finds really important. And so it's really amazing to think now, like, wow, it's only been 8 or 10 years that I've been practicing in genetics, but yet those kids that I saw initially, now we have totally different conversations with them about treatments and what their futures could look like. And I think that's really rewarding.
Yeah. And I think that's another thing too that's good about working like kind of in the clinical genetic space is you see these patients as they're growing older and can talk to them about things that are newer technology wise, but also see how they're growing and becoming their adults and becoming their own person and having to work to start taking charge some of their care as well.
Mhm. Yeah, and that is one thing with being a genetics physician, we can see pediatric and adult patients. Part of our training allows us to be boarded to see kids and adults. It's great because you can take care of the entire family. But it's one of the things I love about the pediatric space is really being able to see the changes that happen with development over time as somebody grows into teenage years and adulthood.
Well, and I think we've talked about quite a few things as it relates to working as a geneticist. If there's one thing that people can take away or one thing you want them to remember from this conversation, what is that? Like, what do you think is the most important thing to remember when it comes to talking about genetics?
Yeah. So goodness, there's a few things. I think if you are a person who thinks you might have a rare disease or be at risk of having a rare disease, genetics is accessible. Talk to your primary care provider. Explore options through things like findageneticcounselor.org or the American College of Medical Genetics. Look around for geneticists in your area. I think that an evaluation could be helpful, even if genetic testing isn't recommended at the end of that encounter. Just being able to talk to somebody about symptoms could be really informative. So I'd say geneticists are real. We're out there. We're available and accessible. But also, if people are thinking about this as a potential career path as well, it's a really great job. It's a really great opportunity to work with science, to work with people, and it's in high demand. We need a lot more geneticists, and so there are tons of employment opportunities at the end of your training pathway. So it's definitely a great job to consider.
Well, thank you. I appreciate you highlighting that and kind of taking the takeaways from folks that might need to see a geneticist, but then also the folks that might be interested in pursuing this as a career. So one thing I do want to wrap up with, because I find that those of us that work in genetics always have a favorite gene, or there's a certain gene that we maybe learned about either on the research side or the clinical side. So I wanted to know if you had a favorite gene and why is this your favorite gene?
Absolutely. I totally have a favorite gene. I didn't realize other people did as well. But my favorite gene is GNAS. It's a G unit subprotein that drives a lot of different hormone and endocrinologic functions. I love this gene because it's really complicated, and it like sparks a lot of my intellectual curiosity. So this gene, GNAS, can be, you can have mutations that happen to it that are activating or inactivating. You can have mosaicism in different conditions, or it can be somatic. It actually has some imprinting factors, so it matters if you inherit it from the sperm or the egg cell. It's kind of coded differently. And then if there is a change with this gene, it can have this huge impact of downstream effects on different levels of, thyroid and calcium and other kind of body hormones, like FSH and LH. So some of the conditions that it can cause are things like pseudo hypoparathyroidism or pseudo hypoparathyroidism, which is just like one of those things you learn about in med school that you think is kind of rare and you'll never see. But I think this year alone, we've seen maybe 3 patients with it at our institution. Wow. So it's one of those things, if you keep an eye out for it, you realize it's a little bit more common. The testing for it's pretty tricky because you can look for sequence variants, but you can also look for methylation patterns. So it's always been a gene that really resonated with me. And so actually when I was in peds residency, I got involved with a project where we were writing the gene review for this topic. Gene reviews is a great resource for anybody who's looking to learn more about individual genetic conditions. But I got involved with writing the gene review for this thinking oh, sure, that'll be a great little project to work on. And the deeper I got into it, I realized this is so complicated. I should have picked something that follows more of Mendelian rules of genetics. But once I got in, I couldn't get out. It was just too exciting. So GNAS, absolutely, hands down, the best gene there is.
Okay, so I just I'm gonna have to look into that because I don't know as much for that. But I always find that there's more kind of complex with genetics than you initially think out there, and there are a lot of genes that they're sometimes they do this, but sometimes it's this way. So it's not black or white all the time.
Yes, I love that lifelong learning aspect of genetics. It keeps us humble. We will never know it all.
No, we won't. But I appreciate you working with us today to just kind of talk in general about what a geneticist does, kind of training a geneticist has, but also the importance of working with a clinical geneticist and how to utilize, both the evaluation and the genetic testing together to try to get bring about a diagnosis or come up with treatment plans. So I just appreciate you being here today and thank you for joining us.
Absolutely. Thanks so much for having me.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all episodes of the show. This link is also in the show notes for easy access. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Check out our Patreon at patreon.com/allaccessdna and consider donating to get bonus content, submit questions for our guests, and connect with other genetic curious individuals. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This helps other people like you discover the show. All Access DNA is hosted, produced, and edited by Kate Wilson. The logo design is by Designs by NKJ. Thanks for listening and join us next time.